So I've been asked to give a talk at BOPA, updating the delegates about recent advances in prostate cancer. And really, I've focused largely on developments in the last year, or at least areas where there have been significant developments in the last year. And some of these developments are actually very recent. I think one of the key challenges, particularly within prostate cancer in the UK, is going to be the recent results from the STAMPEDE trial. We've had many results from the STAMPEDE trial, but on this occasion, we've seen results exploring the impact of Abiraterone on patients with non-metastatic disease. So this is patients with high-risk, locally advanced prostate cancer for whom the standard treatment would essentially be, for most of them, would be 3 years of androgen deprivation therapy with radical radiotherapy to the prostate and, in some cases, the pelvis. And then after 3 years, you stop treatment and follow the patient up and treat them if and when they relapse. This was a slightly complex analysis, but it was a pre-planned analysis looking at metastasis-free survival, and it was combining the M0 populations from the Abiraterone arm, but also from the arm where patients received both Abiraterone and Enzalutamide. In both cases, comparing it to the control arm, which was androgen deprivation therapy alone. Bottom line is that metastasis-free survival is significantly increased if you give 2 years of Abiraterone. And maybe more importantly, the secondary analysis of overall survival is also strongly clinically significant and strongly statistically significant too. So for the first time, what we've shown here is that adding in an androgen receptor targeted therapy to patients with high-risk non-metastatic disease at the time of diagnosis prolongs survival. And this is a lot of patients. So this could have really significant implications for our practice. The other development that I'm updating the delegates about is PSMA lutetium. So this is a relatively novel concept in the UK, although this treatment's been used in other countries for a little while. But this year we've had the results of the VISION trial, which is the pivotal phase 3 trial of PSMA lutetium. So PSMA lutetium is what's sometimes known as a theranostic product, and that is that there's a small molecule linker which binds prostate-specific membrane antigen, which is expressed on the surface of most prostate cancers. And you can link it either to gallium, which enables you to do a PSMA PET scan, which basically identifies which patients have PSMA-positive cancer. And alternatively, you can link it to lutetium, which is a radiopharmaceutical. And so fundamentally in the VISION trial, patients with a metastatic castration-resistant prostate cancer who had received at least one androgen receptor-targeted therapy, such as Abiraterone or Enzalutamide, and at least one taxane chemotherapy, either docetaxel and or cabazitaxel. So these is essentially a group of patients who are relatively advanced, relatively heavily pre-treated, where standards of care are not 100% clear-cut for many of these patients. And they were randomized to best supportive care, which did include some active measures, plus or minus 4 to 6 cycles of 6 weekly PSMA lutetium. And the co-primary overall endpoints were overall survival and radiographic progression-free survival, and it was a positive trial for both of those co-primary endpoints. The median improvement in overall survival is around about 4 months. So this is a potentially practice-changing trial. This is a drug which appears to improve outcomes for men with very advanced prostate and heavily pretreated prostate cancer. It's going to be quite a challenge to deliver because it's a radiopharmaceutical, and so there's quite extensive radiation protection rules that will need to be in place to deliver it. And that requires an infrastructure which a lot of centres have, but possibly don't have on the scale that's going to be required to deliver this to prostate cancer patients. So it's going to present a challenge, but hopefully a treatment which will become available to more of our patients over the coming year or two. The final new development in prostate cancer of interest to the BOPA audience is the advent of PARP inhibitors in prostate cancer. We're familiar with the use of these drugs in ovarian cancer and now a little bit in breast cancer as well. But we now have evidence for the use of Olaparib in men with metastatic castration-resistant prostate cancer. This is based on the PROfound trial. PROfound trial was men with mCRPC who had to have at least had one androgen receptor targeted therapy, such as Abiraterone or Enzalutamide. They may or may not have had chemotherapy as well. And patients were selected on the basis of homologous repair defects. So that's based on somatic tissue-based genetic testing. And that was one of 15 or so different genetic mutations, which would make you eligible for the trial. And then they were randomized to receive either Olaparib or the other one of Abiraterone or Enzalutamide, whichever one they hadn't received previously. Okay, so the primary endpoint was radiographic progression-free survival. Importantly, patients in the control arm could cross over to Olaparib on progression. Despite that, in the primary analysis population, which is actually just patients with BRCA1 or 2 or ATM mutations, so not the whole population, in the primary analysis population, actually there was a significant survival advantage, despite 2/3 of the patient actually crossing over on progression. And so, again, for those patients with a BRCA mutation, so interestingly, on further analysis, the patients with ATM mutations possibly didn't benefit so much from the intervention. And so actually the European marketing authorization is only for patients with BRCA mutations. So for patients with a BRCA mutation, now Olaparib is potentially a life-prolonging treatment option for those men. Now, the challenge here is that this is based on somatic gene testing. So this is tissue testing. You've got to test the patient's tumor. And we don't currently routinely do that test. And indeed, there's a lot of men who don't even get biopsy still. So actually bringing this test into the service is going to be the real challenge here. And it'll identify probably about 8% of patients will have a somatic BRCA mutation. And probably of that 8%, probably only a quarter will have an inherited germline mutation. So the challenge here is going to be doing the tissue testing for these patients. We don't routinely test men with prostate cancer for somatic gene mutations because until now there's been no particular benefit in doing that. This is a technology which is available in most big cancer centres, or at least will have a diagnostic lab, an NHS diagnostic lab that can deliver the test for them, because it's already done in a number of other tumour types like lung cancer, or with BRCA, of course, ovarian cancer. So the capability is there. The problem is going to be the capacity. And that will require finance, but it also requires skilled staff. And I suspect there's a lot of centres to scale it up onto this scale, where potentially we'll look at testing all men with metastatic prostate cancer. It's going to take quite an investment in infrastructure to deliver.